So, my presentation, we are moving from sweaty feet up to bright eyes. I worked on a project evaluating a new technology. If we can use technology instead of a manual examination method. So the study is called Reliability and Validity and the Stability of a Technological Instrument, which is head-mounted, which you see on the picture. This is a one-camera system. We used a two-camera system. I will talk more about that during my presentation. These are some of the guys that I've been working with. You know Stig. He's been helping out with the design of the study. I worked a bit with Professor Harris from Memphis. He's an optometrist working on behavioral optometry. And this is Professor Eric Snyder. He's the one behind the technology that is developed in Munich, in Germany, at the Institute of Clinical Neuroscience, and together with neurologists down in Munich, in Germany. There is now an ongoing project to develop this further, so this is the first study of several studies that will come later. We are now working together with universities in the Netherlands, both in Rotterdam, the Medical University of Neuroscience, and a university in Amsterdam. We are also working together with 4 universities here in the States, and we are working with a clinical hospital for eye diseases in India, in Chennai. So that's more to come. This was the start with this project was the first start of this big project that is now developing. I need to talk a little bit about what we call eye tracking. We can use camera systems to look into the brain. You don't need X-rays, you don't need MRI, you just need to look into patients' eyes because they are controlled by circuits in the brainstem, in the pons, and in the controlling system of a voluntary eye movement system. So these are integrated systems in the brain. So by using cameras, we can actually look into the brain and get some information out. This kind of technology, there are several camera systems being used. Has been used in research for decades, 20, 30 years or even more. Used by those professions in research, optometrists, eye doctors, neurologists looking into the brain, psychiatrists, pediatricians, psychologists, and ENT, that's the ear, nose, and throat doctors. They are looking for better patient care, individual patient care, doing better diagnostics than today's method, get a better differential diagnostics of the patients, and they would also like to monitor treatment. And especially in the pharmaceutical industry, they are using these eye trackers to monitor treatment and to do a monitoring of the dose responses that are given, especially in neurology. You can even use eye movements as biomarkers for help of diagnosing several conditions. There are around 200 diseases being researched to see if there are vision biomarkers that can be used for diagnostics and differential diagnostics. So here you see a small list of pathologies that are being researched throughout the last 20, 30 years. There are pathologies, but there are also Reading disabilities among children, where you see oculomotor dysfunctions being a part of the reading problem. And here in the States, there is a big issue on traumatic brain injuries and concussions, which affect the eyes, one of the parameters. So today, the golden standard for doing this kind of examination is manual, and it's subjective. It's difficult because eye movements are high-speed movements. It's the fastest muscles that you have in your body. So when you flick your eyes to the right or to the left, you move your eyes between 700 to 800 degrees per second. So it's hard for a clinician to read out those eye movements. They are integrated with head movements, so you can compensate the eye movements with the head movements if your eye movements are not proper. So it's very dependent on the clinician and his experience. That means we get a low sensitivity and a specificity in the testing. So we get false positive results or false negative results by doing the examination. And it's difficult to monitor treatment because you examine the patient for, say, a month ago, and then you would look at him 30 days later, and then you can't remember how the eyes were or the small details in the examination. So the study that we started off with was to move from a subjectively examination, where you use the clinician to do a manual examination, into a more objectively and to use technology to do the examination. So we're trying to compare to today's standard, which is using a finger in front of the patient or a small apparatus that is manually controlled, and to get data quality and use technology with high-speed cameras to read out better outcomes from the examination. So this is the background. This presentation will consider the study that we did. This is not finished yet. So the results from the study and the statistics is not ready for presentation. But I will present a new method for doing this kind of comparison studies, which could be used also in pharmaceutical studies. So the aim of such kind of study is to investigate what we call the intra and inter reliability. That will mean you have one investigator examining a patient 2 times, and you look at the intra-reliability of that investigator. And you have another investigator, so you can compare 2 investigators. And then you have a third situation with a technological camera, which you also can do an inter-reliability test with. So that was the aim of the study, to test those technologies towards those clinicians performing the manual technique. Additionally, we wanted to estimate the stability of the technology. That means that you have to run more examinations with the technology and to see if the technology is stable throughout the examination. We took 2 fairly well-known eye movements which we examined in the patients. The first one is called the smooth pursuit eye movement. That is the ability to follow something that is moving in front of your eyes. And the other was the saccades, which is a jerky or jumping movement of the eyes. high-speed positioning of the eyes from right to left or up to down. Smooth pursuit eye movements were also examined during horizontal smooth pursuit and vertical smooth pursuits, and even a circular smooth pursuit. So we tried out a new design. We were considered, or we wanted to randomize the subjects, and we wanted to blind the trial so we get a better outcome of the measures. And we used a design which is called the Latin square design. And I'm going to run through that in a practical way because this is difficult to understand if you haven't seen it before. And the design is allocated in a Latin square table, which I will show you. So we had a reference population of healthy subjects, both children and also adults, more than or up to 70 years of age, which were classified as normal ocular functions in respect to smooth pursuits and saccades. And the study population, that was children and adults that had poor quality or control of the voluntary eye movements in smooth pursuits and saccades, and was classified by opticians or clinicians as abnormal, mildly abnormal or severely abnormal. So most of the subjects had degrees of reading disabilities. There were no pathologies involved. And some were diagnosed dyslexic. So this is the group. We had 6 groups. They were stratified by age. So we had an age group, children from 5 to 12 years age, and then youngsters, and 3 adults group, and 1 senior adult group. And we had a reference population of 1 normal in each group, only 1. And the study population was either a mild dysfunctional subject or a more severe subject. And that was also 1 in each group, each of these age groups. And then we did 2 study periods. We did first the validation of inter-reliability, and then we did this stability investigation of the technology as a second study period. Yeah, and we did randomize both the first procedure and then the second procedure. And this is the Latin square table, so I have to go through that and explain. These are an example of one group. This could be the children group. And we had 1, 2, and 3 subjects in that group. That will be 1 normal, 1 mild dysfunctional, and 1 more severe dysfunctional. And this was allocated in a way that subject number 1 would get its first investigation by the investigator number 1. That will be an optometrist that will take the subject into his office and do the examination manually. So when that was done, it was allocated into the technology where the machine was measuring the eye movements, which would be the E technology. And the next would be the second investigator, the second optometrist doing the same examination. Then the patient needed a rest time because he was doing all these eye movements, so you need to wash out the effect of those 3 investigations. And then you needed to repeat those measures, but then you will start off, for instance, with the technology, and then with the second observer, and then the first observer. So that was the randomization. And then you would do that with the second subjects, but in another order, with a washout period and the repeated measurements. And the second study period would be the stability testing. That was randomized simple by picking out either the mild or the severe patient by a randomization procedure. And they would need to come back 2 or 3 days after the first session to run repeated measurements with the technology. So this is a way of doing a reliability study where you reduce the number of patients. If you do a parallel group design, you will need at least 48 patients. In this design, you will end up with 18 patients, 6 controls, and 12 in the study group. So that was a great design, and also a great design for us in the clinics to perform, because it was easy to handle. It was easy for the patient to do the testing. You need 2 investigators to compare between investigators and between the technology. The randomization and the blinding was easily done, which strengthens the study. And we did this test and the retest of subjects, and they were asked about the tolerability, and that was very good, both in the children group and in the adults. But you need to take this consideration of giving them some rest in between. So no numbers yet for the statistics. I have a big database, which I need to clean up. But maybe next year, if I come back, I'll show you. Okay, thank you.
Somebody have a question?
How long is the washout period?
That's dependent on what you're doing with the patient. In our study, when the washout period was introduced to one patient, we started off with a new patient. And then during that period of time, the other patient was just waiting. And then the second patient was then in the washout period. We started off with the first patient again. So that would take approximately 15 minutes, 20 minutes.
Are they restricted to do something, working with a mobile phone?
Yes, no, they were not allowed to play around with near vision tasks or anything, especially the kids. Yes.
In the phase 2, the washout period was longer?
Oh, the time for the measurements with the technology, that would last for 5-6 minutes. And then they will repeat that measurement for 5-6 minutes, and then they were needed the same time for rest. That would be 15-20 minutes. Yeah, and that was efficient. We will have to look into the data to see if this affected the outcome of the smooth pursuits and the saccades. So if there's a drop in the measurements and it gets worse and worse and worse, that means that we need to increase the washout period. Yeah.
No, you said something? More comments?
I would just observe, when you think about this, that the mechanical, technical equipment is constant. Doesn't get tired. It's just as efficient with the first patient as it was with the 8th. Or the optometrist or a person working has some fatigue factor as they go through their day. They have their own internal rhythms, how they can measure, right?
Sure.
And 2 people are obviously different. And
That's the advantage of a technology and a high-speed technology a high-speed technology would be better than a low-speed camera technology, and it will not get tired. You just push the button and it will come out.
Need a coffee break.
Not a coffee break. Yeah.
Okay. Thank you very much.
Thank you.
For your presentation, and we are looking forward to see the results of your investigation here. So.